Starting dose, begin with 50 milligrams twice daily of quetiapine. This is a moderate starting dose to minimize the risk of initial sedation and hypotension. 2. Titration. After starting with 50 milligrams BD, increase the dose by 50 milligrams every 2 days. So after 2 days, increase the night dose to 100 milligrams. Then after another 2 days, increase the morning dose to 100 milligrams as well. Now the patient is on 100 milligrams BD. Continue titrating. Once the patient is on 200 milligrams BD, assess the effectiveness for symptoms like hallucinations and delusions, and monitor for side effects. If needed, continue increasing by 50 milligrams every 2 days. 3. Monitoring. Monitor the patient for symptom improvement, hallucinations, delusions, and side effects, sedation, weight gain, metabolic changes, etc. Ensure adherence to the prescribed dose. 4. Further increases. Continue increasing the dose up to a maximum of 800 ml a day. The usual therapeutic range is 400 to 800 milligrams per day. The increase should be by 50 milligrams every 2 days, based on the patient's response and tolerance. 5. 6 to 8 weeks at maximum dose. Once the patient reaches 800 milligrams per day or a lower effective dose, maintain this for 6 to 8 weeks to allow the medication to show its full effect. During this period, assess for symptom control and side effects. If symptoms, like hallucinations and delusions, are not improving, consider whether adherence is an issue and check for side effects. 6. When to reevaluate. After 6 to 8 weeks at the maximum dose, if the patient has not shown significant improvement and adherence is confirmed, you might reevaluate the diagnosis for treatment-resistant schizophrenia. Consider switching to a different antipsychotic. If treatment resistance is suspected, you might think about clozapine, especially for cases where other treatments have failed. Alternatively, consider adding an adjunctive treatment if there are other symptoms, like mood disturbances. 7. Adherence check. Regularly check that the patient is taking the medication as prescribed, as non-adherence can often lead to treatment failure. 8. Long-term management. After reaching an effective dose, the goal is to monitor for relapse, side effects, and maintain adherence over the long term. The idea is to gradually titrate the dose, carefully monitor symptom response and side effects, and give the medication 6 to 8 weeks at the top dose before deciding to switch or consider other treatments if the response is inadequate. If, after 6 to 8 weeks of reaching the maximum dose, in this case, 800 milligrams of quetiapine BD, patient has not responded and still has persistent hallucinations and delusions, you would indeed want to consider switching medications. Here's how you could approach the situation. 1. Consider the diagnosis and treatment resistance. If the patient has not responded to adequate treatment after giving the medication enough time and ensuring adherence, this may indicate treatment-resistant schizophrenia. In such cases, more potent or atypical options may be required. 2. Medications to consider. Clozapine is the gold standard for treatment-resistant schizophrenia. It has shown efficacy where other antipsychotics have failed. If clozapine is not an option or the patient is unwilling, you might consider switching to another second-generation, atypical antipsychotic, such as olanzapine, risperidone, aripiprazole, paliperidone, lurasidone. Clozapine is usually considered after failure of at least 2 antipsychotic medications, including one from the atypical class. 3. How to switch medications. The process of switching can be approached in different ways, depending on whether the patient has tolerability issues or side effects. Cross-tapering, gradual reduction of one while increasing the new one. This is a common strategy, especially when switching from one antipsychotic to another. Gradually decrease the dose of thiopine, e.g. reduce by 50 to 100 milligrams every 2 to 3 days, while simultaneously increasing the new antipsychotic. Start with a lower dose of the new medication. Titrate upward based on response and tolerability. The new antipsychotic may be increased gradually over the course of 1 to 2 weeks, while quetiapine is being gradually reduced. Switching without overlap. In cases where the patient has side effects such as sedation, weight gain, or metabolic concerns, you might prefer a direct switch, stopping the current medication and starting the new one. For example, if switching to clozapine, you would typically discontinue quetiapine completely before starting clozapine. Direct discontinuation and restart. Sometimes, especially with first-line atypicals or if the patient has no severe side effects, a direct switch can be made, such as stopping quetiapine and starting another drug, e.g., olanzapine. However, this approach should be done cautiously to avoid abrupt withdrawal symptoms from the initial. If you're switching a patient from quetiapine 400 milligrams BD to another antipsychotic, such as risperidone or aripiprazole, olanzapine, or amisulpride, switching from quetiapine 400 milligram BD to risperidone. Cross-tapering plan. Start by reducing quetiapine gradually, e.g., reduce by 50 to 100 milligrams every 2 to 3 days. Introduce risperidone at a low dose and gradually increase it. Step by step. Day 1, the threne. Reduce to 350 milligrams BD. Start tapering by 50 milligrams. Risperidone. Start with 1 milligrams daily. For the first 1 to 2 days, take once daily, preferably at night. Day 4 to 6. Reduce to 300 milligrams BD. Risperidone. Increase to 2 milligrams daily, 1 milligrams in the morning and 1 milligrams in the evening. Day 7-9, reduce to 250 milligrams BD. Risperidone, increase to 4 milligrams daily, 2 milligram PM. Day 10 to 12, quetiapine, reduce to 200 milligrams BD. Increase to 6 milligrams daily, 3 AM, 3 TM. Day 13-15, quetiapine, reduced to 150 milligrams BD. Increase to 8 milligrams a daily, 4 milligrams AM, PM. Day 60-18, quetiapine, reduced to 100 milligrams BD. Risperidone, increased to 10 milligrams daily, 5 milligrams PM. Day 19-21, quetiapine, reduced to 50 milligrams BD. Risperidone, keep at 10 milligrams daily. Assess side effects and response. After 3 weeks, if the patient is tolerating risperidone well and symptoms are improving, you can discontinue quetiapine completely and continue with risperidone at the prescribed dose. He2, switching from quetiapine 400 milligrams BD to aripiprazole. Cross-tapering plan. Aripiprazole is a partial agonist, so switching can be more gradual. You need to reduce quetiapine at a similar rate as with risperidone while increasing aripiprazole slowly. Step by step, day 1 to 3, reduce to 350 milligrams BD. Aripiprazole, start with 5 milligrams daily, once a day, preferably in the morning. Day 4 to 6, reduce to 300 milligrams BD. Aripiprazole, increase to 15 milligrams daily in the morning. Day 10 to 12, quetiapine, reduced to 200 milligrams BD. Aripiprazole, increase to 20 milligrams daily in the morning. Day 13 to 15, reduced to 150 milligrams BD. Aripiprazole, increased to 25 milligrams daily in the morning. Day 16, quetiapine, reduced to 100 milligrams BD. Aripiprazole, increased to 30 milligrams daily in the morning. Day 19 to 21, reduced to 50 milligrams BD. Aripiprazole, continue at 30 milligrams daily. Assess side effects and response. Once the dose of quetiapine has been reduced to 50 milligrams BD, if the patient is stable and tolerating aripiprazole well, you can discontinue quetiapine and continue with aripiprazole at the desired dose. Switching from quetiapine 400 milligrams BD to olanzapine. Cross-tapering plan. Olanzapine is sedating and has a higher risk of metabolic side effects, so this transition should be done cautiously. Step by step, day 1 to 3, quetiapine reduced to 350 milligrams BD. Olanzapine, start with 5 milligrams daily, take at night due to sedation. Day 4 to 6, quetiapine reduced to 300 milligrams BD. Olanzapine, increased to 10 milligrams daily, still at night. Day 7 to 9, reduced to 250 milligrams BD. Olanzapine, increased to 15 milligrams daily, take at night. Day 10 to 12, quetiapine, reduced to 200 milligrams BD. Olanzapine, increased to 20 milligrams daily, take at night. Day 13-15, quetiapine, reduced to 150 milligrams BD. Olanzapine, increased to 25 milligrams daily, take at night. Day 16-18, quetiapine, reduced to 100 milligrams BD. Olanzapine, increased to 30 milligrams daily, take at night. Day 19-20, quetiapine, reduced to 50 milligrams BD. Olanzapine, keep at 30 milligrams nightly. Once the dose of quetiapine has been reduced to 50 milligrams BD and the patient is tolerating olanzapine, discontinue quetiapine completely. Continue to monitor for potential metabolic side effects, weight gain, dyslipidemia, diabetes, and other side effects such as sedation. SCHAD, switching from quetiapine 400 milligrams BD to amisulpride. Cross-tapering plan. Amisulpride is another atypical antipsychotic but has a different profile, so a gradual crossover is needed. Step by step, day 1 to 3, quipine reduced to 350 milligrams BD. Amisulpride, start with 50 milligrams daily. Take once daily, preferably in the morning. Day 4-6, quetiapine, reduced to 300 milligrams BD. Amisulpride, increased to 100 milligrams daily, 50 milligrams in the morning and 50 milligrams in the evening. Day 7 to 9, reduced to 250 milligrams BD. Amisulpride, increased to 150 milligrams daily, 75 milligram PM. Day 10 to 12, quetiapine, reduced to 200 milligrams BD. Amisulpride, increased to 200 milligrams daily, 100 milligrams AM, 100 milligrams PM. Day 13-15, reduced to 150 milligrams BD. Amisulpride, increased to 400 milligrams daily, 200 milligrams AM, 200 milligrams PM. Day 16-18, quetiapine, reduced to 100 milligrams BD. Amisulpride, continue at 400 milligrams daily. Day 19-21, reduced to 50 milligrams BD. Amisulpride, continue at 400 milligrams daily. Once quetiapine is reduced to 50 milligrams BD and the patient is tolerating amisulpride well, discontinue quetiapine completely. Monitoring during the switch process. While cross-titrating, make sure to monitor the following. 1. Adherence. Ensure the patient is following the new regimen. 2. Side effects. Watch out for sedation, weight gain, movement disorders, especially with olanzapine, or metabolic changes with amisulpride. 3. Efficacy. Keep assessing symptom control, particularly the hallucinations and delusions. 4. Tolerability. Adjust doses based on side effects or inefficacy. If side effects become severe, reconsider the dosing regimen. In all cases, if the medication switch isn't providing adequate symptom control or is causing intolerable side effects, you may need to reconsider either further dose adjustments, a switch to a different antipsychotic, or possibly add-on treatments. This should cover the cross-titration process for quetiapine to risperidone, aripiprazole, olanzapine, and amisulpride. When switching directly from quetiapine 400 milligrams BD to another antipsychotic medication, generally try to choose medications that have similar mechanisms of action and potency. The idea is to minimize the risk of side effects, withdrawal symptoms, or exacerbation of symptoms due to the change in the medication. Direct switch from quetiapine 400 milligrams BT1. Direct switch to risperidone. Why choose risperidone? Risperidone is an atypical antipsychotic similar to quetiapine in that it affects both serotonin and dopamine receptors. It has a higher affinity for dopamine receptors compared to quetiapine, making it more potent for treating positive symptoms like hallucinations and delusions. However, it can have more EPS, extrapyramidal side effects, compared to quetiapine, so monitoring for movement side effects is crucial. How to switch. Step 1. If the patient is on quetiapine 400 mg BD, 800 mg daily, you can start risperidone at 3 to 4 mg daily, usually once at night. This dose should be sufficient for switching, as risperidone's potency is higher than quetiapine. Step 2. Gradually reduce quetiapine over the next 5 to 7 days, starting by lowering to 350 milligrams BD while the patient is on risperidone. Step 3. Monitor for any side effects and adjust the risperidone dose if needed, up to a maximum of 6 to 8 milligrams daily, depending on the patient's response. Side effects to monitor: tardive dyskinesia, sedation, and metabolic effects. T2. Direct switch to aripiprazole. Why choose aripiprazole? Aripiprazole is a partial dopamine agonist, so its profile is different from quetiapine's. It is less sedating, has a lower risk of metabolic side effects, and may be a good option for patients who struggle with weight gain. However, it can be activating, so it's important to ensure that the patient is not too agitated or restless. How to switch. Step 1. Start aripiprazole at 10 milligrams daily, once daily, ideally in the morning. Step 2. Reduce quetiapine to 350 milligrams BD and continue to monitor the patient. Step 3. Gradually reduce quetiapine by 50 milligrams every 2-3 days until it is discontinued completely after about 5 to 7 days. Step 4. You can increase aripiprazole to 15 to 20 milligrams daily if necessary, but this should be done based on patient response and tolerance. Side effects to monitor. Restlessness, akathisia, and insomnia are common with aripiprazole. SOC 3. Direct switch to olanzapine. Why choose olanzapine? Olanzapine is another atypical antipsychotic with a broader efficacy profile and less risk of EPS than risperidone. It also has a more sedating effect, which may be helpful for patients with significant agitation or insomnia. However, it comes with a higher risk of metabolic side effects, weight gain, diabetes, dyslipidemia. How to switch. Step 1. Start olanzapine at 10 milligrams daily, preferably at night due to its sedating properties. Step 2. Reduce quetiapine to 350 milligrams BD and continue monitoring the patient. Step 3. Gradually reduce quetiapine by 50 milligrams every 2 to 3 days until discontinuation. Step 4. If needed, increase olanzapine to 15 to 20 milligrams daily to achieve symptom control, especially in cases of persistent symptoms. Side effects to monitor: sedation, weight gain, and metabolic changes. Top 4. Direct switch to amisulpride. Why choose amisulpride? Amisulpride is an atypical antipsychotic with a unique profile. It works as a dopamine antagonist at high doses for positive symptoms and as a serotonin antagonist at low doses, making it effective for both positive and negative symptoms. However, it has a higher risk of prolactin elevation and may not be suitable for patients at risk for hyperprolactinemia. How to switch. Step 1. Start amisulpride at 100 milligrams daily, preferably in the morning. Step 2. Gradually reduce quetiapine to 350 milligrams BD while monitoring the patient. Step 3. Reduce quetiapine by 50 milligrams every 2 to 3 days until 50 milligrams BD. Step 4. Increase amisulpride to 200 to 400 milligrams daily, depending on the patient's response. If necessary, split doses, e.g. 200 mg, 200 p.m. Side effects to monitor: prolactin elevation, sedation, and EPS. Amisulpride is a potent antipsychotic, and while it is effective for both positive and negative symptoms, it does require monitoring of certain factors. Prolactin levels. One of the major concerns with amisulpride is its potential to increase prolactin. This could lead to sexual dysfunction, galactorrhea, or even menstrual disturbances in females. If a patient is switched directly to amisulpride, regular monitoring of prolactin levels is crucial, especially if the patient is showing any signs of these side effects. Side effects. Although amisulpride tends to have a lower incidence of EPS compared to drugs like risperidone, it's still important to monitor for any emerging side effects. The sedation effect is something to watch out for, though it's generally less sedating than olanzapine. However, this could vary from patient to patient. Summary of the direct switch strategy. Here's a quick summary of the direct switch approaches. 1. Risperidone. Start at 3 to 4 milligrams daily, then gradually. Let's start again, and I'll walk you through the augmentation strategy when a patient is on that might still persist after the initial treatment. D1. Augmentation for mood symptoms, e.g., depressive features, mood instability. When you're treating a patient with schizophrenia who is on quetiapine, codarpaline, but still has mood symptoms like depression, anxiety, or mood instability, you might consider adding a mood stabilizer or antidepressant. NAPSH-A, lithium, mood stabilizer. Indication: lithium is useful if there are mood instability symptoms, which might include mania, hypomania, or bipolar-like features in schizophrenia. Starting dose: 600 milligrams daily, divided into 2 doses, morning and evening. Gradually increase the dose, aiming for 900 to 1200 milligrams daily, depending on the patient's response and tolerance. Precautions. Monitor serum lithium levels regularly, aiming for a therapeutic range of 0.6 to 1.0 ml per ml. Check renal function and thyroid function regularly, as lithium can affect both. Watch for signs of toxicity: nausea, tremor, ataxia, confusion, and agitation. Side effects: tremor, weight gain, increased thirst, frequent urination, polydipsia, and cognitive dulling. B. Sodium valproate, alternative mood stabilizer. Indication: if lithium is not suitable due to side effects, contraindications, or patient preference, sodium valproate is another option, particularly for bipolar-like symptoms. Starting dose: start with 500 milligrams daily, usually in the evening. You gradually increase the dose, aiming for 1,000 to 2,000 milligrams daily, based on the patient's response. Precautions: monitor liver function and platelet count because sodium valproate can affect both. Watch for sedation, which is common at higher doses. Side effects: sedation, weight gain, GI upset, nausea, diarrhea, and hair thinning. 2. Augmentation for depressive symptoms, e.g., low mood, anhedonia, fatigue. If your patient is still experiencing depressive symptoms despite being on quetiapine, adding an antidepressant might be beneficial. SSRIs, selective serotonin reuptake inhibitors. Indication: SSRIs are first-line agents for treating depressive features in schizophrenia. Starting dose: fluoxetine, start with 10 to 20 milligrams daily and increase if needed. Sertraline, start with 25 to 50 milligrams daily, increasing gradually if well tolerated. Precautions: watch for serotonin syndrome when combined with other serotonergic medications. Monitor for any signs of mania in patients who may have a bipolar component to their illness. Side effects: sexual dysfunction, GI upset, insomnia, and weight changes. B. Starting dose: venlafaxine, start with 37.5 milligrams daily and gradually increase to 150 to 300 milligrams daily. Duloxetine, start with 30 milligrams daily, increasing to 60 milligrams daily. Precautions: monitor blood pressure regularly, particularly with venlafaxine, as higher doses can raise blood pressure. Be vigilant about serotonin syndrome when used with other serotonergic drugs. Side effects: nausea, sexual dysfunction, insomnia, and potential hypertension at higher doses. Gang 3. Augmentation for psychotic symptoms. It's still persistent despite quetiapine. If the patient is still experiencing psychotic symptoms, like hallucinations or delusions, despite being on quetiapine, you might consider augmenting with a second antipsychotic or switching to another agent altogether. ADER. A. Aripiprazole, partial D2 agonist. Indication: aripiprazole is useful for residual psychotic symptoms or cognitive symptoms, especially if the patient is experiencing negative symptoms like flat affect or cognitive difficulties. Starting dose: start with 5 milligrams daily. Gradually increase to 10 to 15 milligrams daily, depending on the patient's tolerance and symptom control. Precautions: monitor for akathisia, restlessness, and agitation, especially at higher doses. Side effects: restlessness, insomnia, anxiety, and sedation. At 4. General approach to augmentation. Start low, go slow. Start with a low dose of any augmentation agent to minimize side effects, and then gradually titrate up based on response. Monitor. Regularly monitor side effects and symptom